introduction, Dr. Boyd is one of our attending physicians here in the emergency department. She's also one of our toxicologists as well. She did her medical training here at Albany Med as well as her residency, but then her toxicology residency or fellowship, was done at Emory University School of Medicine in Atlanta, Georgia. So other than being, she's just a fantastic attending physician and very bright. She also tends to be getting me in trouble because I'm friends with her on Facebook, and now instead of dogs, my wife wants goats. So thank you, Dr. Boyd, for agreeing to do this. So
absolutely happy. And if you need goats, I have 2 goats that are probably going to start yelling outside my window any moment now because they want to come inside. So if you want to borrow them anytime, they are yours, my friend. So thank you. Hi, everybody. Thank you guys for having me. So yeah, like Art said, my name is Molly Boyd. I am one of the associate professors of emergency medicine. I work primarily nights. If you are on the night crew, you have definitely seen me and heard me say some very terrible things. If you are on the day crew, hopefully you haven't heard too many terrible things come out of my mouth, but you certainly could have at some point in the past. I've been strictly nights for about 5 years now. I also, in addition to emergency medicine, I also do medical toxicology. So that's going to be your overdoses, whether they're of illicit drugs or unintentional overdoses. Somebody accidentally takes too much of their beta blockers. And I am part of the addiction medicine group. So we have an addiction medicine clinic up in Latham, where we primarily treat opioid addicted patients using Suboxone. So today we're going to talk a little bit about all of the new illicit drug trends. Last time I saw you guys, it was pre-COVID, and we talked a lot about fentanyl, carfentanil, and a lot of like K2 and spice and bath salts were the newest rage. These days, we're kind of going back old school. We're going to talk a lot about the opioids, the new opioid trends, and marijuana, which is big on the scene. You can't even walk through the mall without smelling somebody smoking weed in there. So there's been a lot of changes there in our opiate and illicit drug landscape. I wish I had financial disclosures, but I have none. So let's start out talking about opioids, and we're going to talk about heroin and fentanyl. So working at the Suboxone clinic, we drug test all of our patients every time they can't come in, and they come in weekly. And you guys may or may not know that a lot of drug tests don't pick up all illicit drugs, but when we go to our clinic, we can do, instead of just the urine dips like we do at the med, we do like GCMS, mass spectrometry. So we're doing some really in-depth studies of what people are taking. And the good news is, you might be surprised to hear that we have fixed the heroin problem in Albany. There is no more heroin in Albany. And why is there no more heroin in Albany? Because it's all fentanyl. You can have a patient who's coming in and says, oh, I just took a lot of heroin, and you test their urine for heroin, and they look like heroin, and they say they're using heroin, and they have vials of heroin in their pocket, but the drug test is negative. And that's because everything is fentanyl. Why fentanyl? It's way more potent. It's fast on, fast off. It gets you really high, really fast. But one of the problems is it redistributes into the fat. So unlike heroin, which maybe you'd be high for an hour or two, fentanyl, the first time you use it, you guys know, you give fentanyl all the time. It hits them really fast, but then it comes off really fast. But it doesn't come off because you metabolize it really quickly. It comes off because you're redistributing it into the fat. So it's no longer acting on your receptors. It's just kind of redistributing itself. It's getting a little less potent. As long as you only use it once or twice, it's essentially out of your system. But for patients who are using it regularly, the fentanyl very slowly builds up in their system, and they have a chronic reservoir of fentanyl in their system. Back in 10, 20 years ago, illicit opiates, things that killed patients, and we all know 100,000 people die per year of overdoses. The vast majority of those are opioid overdoses, but we can't say anymore that those are all heroin overdoses. These are synthetic opioids like fentanyl, Not really carfentanil anymore. That was a thing about 5-6 years ago. That's kind of fallen out of favor, but acetylfentanyl and other fentanylogs are out there in any number with different activities. Now, fentanyl is not just in the heroin. Fentanyl has made its way into basically every other drug in our community. I've had patients who come in after what's very clearly an opiate overdose, and they get Narcan and they wake up. And when you talk to them, they're like, I didn't use opiates. And you're like, yeah, I'm sure you didn't use opiates. And at least twice now, I've had a patient come and look at me directly in the face and said, no, I didn't use opiates. That's not my thing. I was smoking crack. And people aren't going to lie about that. Yes, some people say I was smoking marijuana and there must have been fentanyl in that. Yeah, I'm not sure I believe that all the time. But if you say you're smoking crack, but it turns out to be fentanyl, I don't think you're going to lie about that. There is fentanyl in all of the drugs. There's fentanyl in cocaine. There's fentanyl in meth. There's fentanyl, even probably in marijuana, although it's not necessarily as frequent as some of our patients would like us to see. So when it comes to fentanyl safety for our patients, and we're seeing these patients, and you're getting patients, they're either getting Narcaned by their friends, by their family, by bystanders, by us. The likelihood of overdose is a lot higher than it was a few years ago. And the reason is because fentanyl is so potent. If somebody who's making cutting fentanyl, if somebody who's cutting fentanyl makes a very, very simple mistake, you're going to go from having a drug that'll get you high to a drug that's potentially very dangerous. And believe it or not, these people aren't spending a lot of time making sure that their fentanyl and their baking soda is mixed really well. So in the same distribution of fentanyl, you might have something that barely makes patient X high and is lethal to patient Y. They do sell fentanyl test strips. And I think at one point we were advocating use fentanyl test strips. Make sure your heroin doesn't have fentanyl in it. And these test strips, you can buy them on Amazon. They're like $2 each. Local services like Catholic Charities and Choices, even Spark, you can get them for free. At this point, there's really no point in testing your heroin to see if it has fentanyl in it. You should actually be testing your fentanyl to see if it has heroin in it. But if you're going to be using cocaine, if you have patients out there, if you have friends that are using out there and they're using cocaine, they're using meth, they're even using marijuana from a source that they're not completely sure about, they should really be testing it because people are getting sick and dying. We actually had a patient recently, and it was an incredibly sad case. A very, very kind woman was smoking crack with her husband and came in after an opiate overdose. And she was Narcaned. She had probably no crack in her system. Her husband came and visited her and she was on a Narcan drip. She was admitted to the hospital. He went home and he smoked more crack and he overdosed and died from smoking crack. Now, it's very clear that that crack had fentanyl in it. And I guess it was he just didn't understand why she was so sick. And that was a fatal mistake for her. But these are available. They're available. They're $2 for a test strip, and they could certainly be saving lives. So why fentanyl? Yeah, it makes people higher, but it's also way easier to get into this country. So if you're going to transport a kilo of heroin across the border from Mexico, which is where it's very frequently coming, that's $75,000 worth of heroin once it's cut. If you're going to transport a kilo of fentanyl, you're going to tape it to your body, you're going to eat it, you're going to be a body packer. That's $1.3 million. And it's so much more money because a kilo can be cut into many, many, many more doses. By the time it's cut, users use the same quantity of material. And these little baggies down here are supposed to be about the size of what a bag or a dose of heroin would look like. So in one of these little baggies, you're going to get a dose, whether it contains fentanyl, whether it contains heroin, whether it contains some other illicit substances. in theory, the drug dealers want to give you what you would want to use one of. People will use a bag a day. Some people use a half a bundle, or a bundle a day is not unusual amounts of drugs. There is some talk about Suboxone being distributed through EMS. I don't know where we stand in terms of the legality of that, but I can tell you that Suboxone is an amazing, amazing medication that saves many, many lives. So people come in, they get found on the street, they're an overdose, they get Narcan, they're awake for some period of time, they come into our emergency department and they're in fluid withdrawal, or there's some level of withdrawal. And we want to make them feel better. And there's a couple of ways that they can feel better. We can give them some benzodiazepines. We can give them some fluids. We can give them some Zofran. But ultimately, the Narcan that they're given knocks the fentanyl off of their receptors, and they are in fluid withdrawal. So at some point, we want to get them out of withdrawal. We don't want them leaving the emergency department. We don't want them combative. We don't want them angry. We want them as comfortable as possible. And we want to put them in a situation where maybe they know that there's help out there, and that help out there very well could be Suboxone. Now, Suboxone isn't a miracle medication. There's not, it's not the one magical fix-all, but gosh, it comes awfully close. It can overcome Narcan and bind to the receptors of somebody who is on, it can overcome the receptors, bind to the receptors of somebody who's on fentanyl, addicted to fentanyl, gets given Narcan, and can get them out of withdrawal and just make them feel a little bit better. 5 years ago, when all anybody was using was, oh my goodness, let me make my phone stop for a second. I apologize. I'm getting a consult about Suboxone. So that was another text about Suboxone. So 5 years ago, when all there was heroin in the community, patients would take their heroin. It would last about an hour, maybe 2 hours. You would give them a single dose of Narcan. And after the Narcan wore off, the heroin would wear off too. You would start them on Suboxone. They would start feeling better. One of the issues with fentanyl and how it changes the way we're doing things, and if eventually Suboxone becomes something that we are able to do pre-hospital, it's going to be a little bit more difficult, because the fentanyl sits in your system for so long that if I am going to give you a single dose of Suboxone as a heroin addict, it's going to make you feel better. Sometimes as a fentanyl addict, because there's so much fentanyl in your system, your receptors are just so used to having this constant supply of fentanyl. If we start giving you Suboxone, we knock the remaining fentanyl off your receptors. It actually makes you feel worse, not better. So, that's going to be an issue in the future pre-hospital. Right now, it's a very big issue in the hospital. If I give you a Suboxone and you're high, it's just like giving you Narcan. And you guys have seen patients who get Narcan, and you know that it can make them very, very uncomfortable. I imagine there's not a person who's listening to this webinar who has not given Narcan to a patient. With fentanyl and some of the fentanyl analogs, it does change the game on Narcan a little bit. 5 years ago, I give you a 2-pack of the nasal spray. You give a single dose and your patient's going to wake up adequately so that you can transport to the hospital safely. With fentanyl, it binds much, much more strongly to receptors. So the Narcan nasal sprays might not give you the results that you're looking for. If you have somebody, you come in, they're pinpoint pupils, they have a low respiratory rate, they're just this side of coma, you give them a dose of Narcan, you expect them to wake up to at least a certain degree. With fentanyl, that might not be the case. With fentanyl, we advocate for higher doses of Narcan. There's very few times when Narcan is not indicated in a patient that you suspect an opioid overdose. Pinpoint pupils, low respiratory rate equals Narcan in my book. And if the first dose doesn't work, give them a second dose. If you don't have IV access, the nasal spray is the perfect thing to use. It's very, very effective. It doesn't require IV access. If the first 2 doses of the nasal Narcan aren't working, by the time at this time, you're working on IV access on the patient, then we switch over to an IV formulation. In patients that you already have IV access on and you're going to use IV Narcan, I like to go lower doses. I think the traditional teaching is 2 milligrams of Narcan. If you have a patient and your first go-to is IV Narcan. You haven't tried the intranasal because you have the IV established. I go with lower doses. The traditional teaching is 2 milligrams. I say either a 0.5 milligram or 1 milligram in these patients because you want them to be awake, but you don't want them to punch you. However, if you've already given 2 doses of nasal Narcan, nothing has happened. I just go right ahead with the 2 milligrams of Narcan, and you can even repeat that. It is literally impossible to overdose on Narcan. I have patients on drips of 8 milligrams of Narcan per hour, and if you overdose on Narcan, literally nothing happens to you. So if you're not sure if you should give another dose of Narcan, the answer is generally yes. If they're comatose, pinpoint pupils, low respiratory rate, more Narcan, absolutely. That being said, be aware, the problem with giving too much Narcan is not that they overdose, is that they unoverdose. And then you have a very unhappy, addicted patient who you just probably stole from grandma in order to get their high, and you took it away from them with Narcan. So they're probably not going to be happy with you. Narcan lasts about an hour, maybe about 2 hours. Oftentimes it lasts longer than the real high of the patient. We still want these patients to come into the emergency department, although we're allowing them to RMA more frequently than we did in years past. But there is a real chance that somebody gets a dose of Narcan, wakes up, is trying to fight you, and then when the Narcan wears off in an hour, maybe 2 hours max, they start becoming somnolent again. So for these patients, we do want them to come to the emergency department if it's safe or humanly possible. And we certainly want them to go home with some nasal spray when they get here. I stole this picture off the internet. You can see that Walgreens is like advertising Narcan. You can get it free from Walgreens. With the recent rash of overdoses in Rensselaer County, the health department put out a statement. There's actually a phone number you can text message, and I found it by Googling free Narcan, Rensselaer County. You text message a phone number and they will send you Narcan free to your door if you're a resident of Rensselaer County. So if you go Google free Narcan near me, you'll be able to find free Narcan. And it's a good thing for all of us to have in our cars. If you have a friend that uses, make sure they have it, make sure their friends and family have it, and make sure they know if they ever have to use it, they should come to the hospital. And guys, if you do have questions, comments, or concerns, please feel free to interrupt or ask questions. So Narcan nasal spray is the go-to for overdoses, but new, just hitting the market. We actually just FDA approved and will probably be hitting the market in about 6 months or so is OPV. Now, OPV is the same concept of Narcan. It is an opioid antagonist. So it kicks fentanyl off of your receptors, binds to those receptors. And if you are in an overdose, it wakes you up so that the fentanyl can no longer be bound. The difference between OPV or nalmefene is that it lasts about 6 hours. And there's pluses and minuses to this. And I don't know how exactly it's going to play out in the next couple of months as this starts becoming available on the market. It would be great to have a medication that we can give somebody that lasts 6 hours. If you're in the field and instead of giving something that lasts 1 hour and maybe they'll go back into an overdose state and need to get re-Narcaned, you give something that lasts 6 hours and the vast majority of all opiates are going to be clear from their system by 6 hours. So this could really be a game changer in the field. In the emergency department, if they're already here and I have them staying, I'm going to be giving them little tiny baby doses of Narcan just so I can keep them. I want them asleep, but breathing. So this is not a medication that I could see myself using unless somebody's trying to leave AMA. And I'm like, before you go, one more spray in an attempt to keep them from having their overdose recrudesce. So 5 years ago, it was heroin. 1 year ago, it was fentanyl. And in that period, there were all the fentanylogs and like carfentanil, which thank goodness has gone away. Now there's new synthetic opioids that are even stronger and less responsive to Narcan. So the zines, there's nitrazine, isotinazine, called iso, medo, and edoniazine. And they are synthetic opiate analogs. So just like fentanyl in that regard, they bind the same receptor, but but they bind much, much more strongly. And people are really starting to love these medications. This is commonly found in what was supposed to be heroin is actually fentanyl, probably has some of the zines in it, and it's becoming more and more popular. So this is going to present exactly like a heroin fentanyl overdose. Patients are going to have pinpoint pupils. They're going to have low respiratory rates. They might have coma. They might be in cardiac arrest, or they might just be a little bit sleepy. But these patients, you're going to give your first dose of Narcan. It's not going to work. You're going to give your second intranasal dose of Narcan. It's not going to work. And you're going to be looking at this patient. You're going to be like, I've seen opiate overdoses before. This is an opiate overdose. And these are the patients where you're going to want to give IV. And like I said, if they've already gotten 2 doses of intranasal Narcan with a short period of time for them to actually get into their system, and it's not working, those are the patients I'm just going ahead with the 2 milligrams of IV Narcan. If IV Narcan is if I already have an IV and I haven't given the intranasal, I go with the lower doses, like 0.5, repeat it. And then for a grand total of 2, maybe 4 in these patients. If Narcan doesn't work, obviously we're bagging them. We might be intubating them. So heroin is now fentanyl. It might have some of the zines in it, but even more popular and possibly more horrifying. If you didn't know you've seen Tranq or xylazine on the streets, I can guarantee that you have. This has really just come into the limelight in the Albany region in maybe the past 4 or 5 months. It's been around nationally for about a year or so. It was really big in Philadelphia for a while, but it is another medication that you're going to find in heroin. It's like clonidine. So it works differently. It doesn't really react to Narcan. It's a alpha-2 agonist. So if you think of your alpha-2 agonist, those are like your pressors, right? You give an alpha-2 agonist and it squeezes your blood vessels and it increases your blood pressure. And when you first take xylazine, that's what happens, but then it crosses your blood-brain barrier and it acts centrally and the exact opposite happens. So at first you're tachycardic hypertensive for a very brief period of time, and then you become bradycardic and hypotensive in addition to the fentanyl overdose. So it's a common adulterant. It's oftentimes in the fentanyl. It's occasionally in cocaine. And you will have a patient who comes in with very clearly a fentanyl overdose. They may or may not respond to Narcan because it will make you sleepy. It's called Tranq. It's actually an animal tranquilizer. Veterinarians are very familiar with this medication. So they may or may not respond to Narcan, but you'll notice they're very bradycardic. And I've had a couple of patients recently they're just sleepy and bradycardic. And the reason it's in the drug supply is fentanyl is a great way to get high, but it goes away very, very quickly. So Tranq makes the high a little bit better and lasts a little bit longer. It makes them a little bit more euphoric. But the side effects, again, initial hypertension followed by bradycardia, hypotension, somnolence, and coma, which is going to be added to by the fentanyl overdose. One of the kind of ways other than the bradycardia you can tell that somebody was on it, one of the very odd complaints is that they have a dry mouth afterwards. So if you ask them, like, you overdosed, your bradycardic, do you think you took something different than usual? They're like, no, it was the usual stuff. It was the same guy. Are you really thirsty? Do you have a dry mouth? And that's one of the telltale signs of Tranq. There's actually another telltale sign of Tranq. It might not be as noticeable at the initial usage, but after using Tranq for a period of time, this is starting to be known as the zombie drug. Years ago, it was really big. Crocodile was a morphine analog that was commonly used mostly in Russia, where you would see those horrific photos of people who had these necrotic wounds in their arms. And I was very confident 5 years ago that Crocodile wasn't going to come to America just based on how it's manufactured. But instead of Crocodile, we have Tranq, and Tranq does something very, very similar. So it vasoconstricts, and it can actually vasoconstrict peripherally so tight that you start getting these lesions. And you're not getting the lesions like abscesses in the site of the injection. You could potentially get these lesions anywhere in your body from this vasoconstriction. So I'm sure we've all seen patients, IV drug using patients who have these weird abscesses and lesions. And you're like, oh yeah, that's where he injects. That's where it came from. But then we start seeing things like this. And this guy didn't inject in his leg. He had vasoconstriction. This isn't actually an infection. It's just necrotic tissue. It's a setup for infection. But you've all seen these patients, and these are young, otherwise healthy patients whose skin is quite literally rotting off of them. In 2014, it was first being seen. In 2019, there's positive xylazine in up to 80% of the heroin fentanyl that was confiscated in Philadelphia. So it was there then, it's coming here now.
Dr. Boyd, one of the questions out there is they wanted to know what would be the reason for dysarthria with the Trenk's symptoms.
I think it actually has to do, great question. Thank you for reading my slides. I think it has to do a lot with actually the dry mouth. So it's not true dysarthria. If you've ever seen somebody who like took too much Benadryl and their mouth is just like a cotton ball and they're trying to talk to you, and we've stroke paged these patients, you're like, I can't hear what they're saying. It's just they can't get the words out. They can't form the words because their tongue is like literally stuck to the top of their mouth. Or they're, in addition, they're sleepy, they're tired, but that plays a big role.
Thanks.
Now test strips are coming on the scene for Trank. They hopefully in the next couple of years or next couple of months, they'll be FDA approved. A lot of people are against it. Like senators they don't want to enable drug users. They don't want to be like, fentanyl is fine, but you better test it for Trank. They think that's actually going to cause people to think that doing drugs is okay. And I want to do everything in my power to tell people, no, fentanyl is not okay. But I think xylazine's probably a little bit worse at this point. So if we can have people test their stash, it doesn't take that much. Like you literally take a drop of fentanyl, you take a drop of water, you stick it on one of these test strips. And if it turns pink, it has Trank in it. And then you have to decide whether you're going to use it or not anyway. Oh, I keep on pressing the wrong button there. If anybody has any questions, I am happy to answer them before we move on. But I think the key takeaways for that are Narcan absolutely works. Narcan is absolutely safe, with the biggest real side effect of somebody waking up and becoming agitated. But in some of these stronger medications, Narcan is not as effective, and we're going to need higher doses, and we have to titrate it to the appropriate effect. And I want these patients asleep, but breathing. It's kind of hard to do when you're using intranasal, but if we can titrate the IV stuff correctly, it will help us manage the patient better.
Just one more, Dr. Boyd. Can you speak a bit about pre-hospital care to treat the wounds of Trank? You know, is it just normal saline, clean bandaging?
Normal saline, clean bandaging. The key is not to get them infected and to prevent any tissue deterioration that we can. So like a dry dressing so that when we pull off the dressing later, it doesn't stick to them. If there is like a sock stuck on there, like glued on there, as you can imagine they could be, we're just not going to touch it. We'll soak it, we'll cut it, we'll do everything we can to remove it without removing too much skin. And then the question about whether it needs antibiotics and how their pulses are distally, if it needs like an intervention, or if they just need to stop using Trank.
Thanks.
So switching gears a little bit, we're going to switch gears to a little bit of a pediatric presentation. And this is a case that, again, like if you guys haven't had this, you will. And it breaks my heart because you will get a call for an altered child. They're previously healthy. They're generally, toddler age, put things in their mouth age. And in this particular case, this is an actual case of a 3-year-old female. You walk into the house and you look around and you're like, this is a normal family. This is a caring, loving family. But the kid is altered, somnolent, they're flaccid, they're moaning to sternal rub, they're maintaining their airways, so you're not going to intubate them. You grab a finger stick, it's normal, they're afebrile, but they're tachy and hypertensive. So you look in their eyes, 5 millimeter pupils. If you notice that, you might see they have nystagmus, their cheeks are a little bit plush, flush, but the rest of their examination is normal. Their lungs are clear, the abdomen is fine, their bladder is okay, their abdomen's non-distended, their bladder's non-distended, but they're not moving. They're like withdrawing, they're flaccid. During you don't need to intubate them, maybe establish IV access, you pick them up, you go. You're thinking, this kid is septic, I need to get them to the hospital. I hope I get them there before they needed to be intubated. During transport, they Brady down to 30. And this is a particular case that I have seen. And if you haven't seen, you will see. And the title of this half of the lecture is Marijuana and the Pediatric Population. Wait, pot can do that. People have been using marijuana for thousands of years. The most marijuana kind of use, especially by high school students, kind of peaked in the 1980s. And I feel like it's probably going to peak again soon. As of 1970, it became a Schedule I, and that it is still technically a Schedule I, but it's decriminalized in the vast majority of the country, including New York, who just opened up its first dispensary in the capital region about a month ago. So there's not only, but because marijuana was a Schedule I, it's really hard to do experimentation. And people knew that marijuana, A, isn't bad for you, and B, has a lot of medical uses. So John Huffman started doing research and started creating synthetic THC so that they could have the health benefits of THC without the illegalities of marijuana. And that's actually how Spice, or K2, was created, the synthetic cannabinoids. So I think that whole project backfired on him. A little background on the kind of lingo and what is exactly out there in terms of cannabis, because cannabis wasn't an issue. Prior to, again, like 5 years ago, there was no EMS calls for marijuana. There were no emergency department visits for marijuana. I started at Albany Med in the emergency department in 2009. And I think up until around 2017, 2018, I can remember 2 marijuana patients that came in for marijuana. Great stories. Ask me about them sometime if you see me. But since then, everybody has marijuana hyperemesis. We're having patients who are obtunded from marijuana, and then we're getting these incredibly sick pediatric ingestions. When you talk about cannabis, cannabis is the plant. There's 2 different types of it. There's the sativa, there's the indica, and experienced pot users will say, oh, I like sativa better, I like indica better. And the reason that those are 2 different is because they have different amounts of their biologically active cannabinoids. Now, the delta-9 tetrahydrocannabinol, that's delta-9 THC or THC. When you're talking about THC, that's it. And that's the major compound that we think about in it. There's also CBD, which made the news recently. There's cannabinol, and there's about 50, 60 other compounds that have some sort of activity to them. And depending on the amount of these different cannabinoids, depends on how it makes you feel. Some are kind of upper, some are kind of downer, some make you paranoid, some make you sleepy. But why smoke pot when you can turn it into cannabis oil? You can turn it into concentrates. You can soak it with butane and turn it into wax or shatter or dabs. So you take something that normally has about a 4 or 5% THC concentration, and you turn it into this concentrate that's like 90%. Hemp is the fiber of cannabis. It has a very, very low concentration of CBD, almost 0 THC, and can be used. I mean, it grows. They call it weed for a reason. If you plant it, it will grow, and you can make shirts out of it. You can make paper out of it. It's a really great, great plant. You can take it and get extracts out of it. So you can have THC extract, you can have CBD extract, you can have ones that have a certain concentration of delta 10 THC to delta 9 THC. So it kind of changes the way your mood is. And then they start with edibles, which are honestly, they're the bane of my existence, because edibles have varying amounts of THC and CBD. They can be very, very strong, and people tend to overdose on them regularly. Why does it even matter? Because we have endocannabinoids in our system. We actually have receptors for THC. Our endocannabinoid system, it's actually thought, like years ago, we thought that our mu receptors, our endogenous opioids, were the cause of like the runner's high. But now more and more information is coming out. We think actually the endocannabinoid system has a lot more to do with that. It helps regulate mood. It helps regulate appetite. It helps regulate your emotions. So THC is going to bind to those two receptors. And there's strong evidence that it helps. Like marijuana, when used appropriately, there's strong evidence it helps chemo-induced nausea and vomiting, spasticity, chronic neuropathic pain. Some people it helps with anxiety. Some people does the exact opposite. I'm sure you guys have seen those patients. Maybe it helps with other neurologic problems like Tourette's, fibromyalgia, chronic pain. Maybe it even helps with opiate addiction. And there's more and more data that shows that it can be helpful in those patients. Maybe PTSD, maybe Parkinson's, maybe schizophrenia, maybe glaucoma. There's not even good evidence for glaucoma. But instead of being like, years ago, instead of being like, hey, go smoke weed for your glaucoma, they created concentrates like Marinol, Epilodex, which is an anti-seizure medication used in pediatric patients. So you couldn't smoke weed, but you can get these highly modified compounds. Like I said, it's been medically legal in New York since 2014. And as of March 31st, 2021, it is recreationally legal, which I think has really changed the landscape of basically everywhere. You can't walk through the mall without feeling like you're being hotboxed, like you're at like a keg party in college. I was coaching Little League and there were people like openly smoking marijuana at a Little League game. And like, I think we might be taking it a little bit too far when it gets to there. And although I think it is a great medication, has many medicinal uses, I think it's great for anxiety. I recommend it to patients with pain, with opiate addictions. There's also some problems with it. It is safe. It is nearly impossible to overdose on a marijuana cigarette. So to overdose, you need to get 50 to 70 grams of THC. And that's equivalent to somewhere between 200 and 1,000 joints per day. Now, if you can smoke 200 to 1,000 joints per day, I think a THC overdose is probably the least of your problems. So the typical dose is about maybe 10, maybe 50 milligrams of THC, maybe a joint or edibles. They actually tell you how much is in it. So the 10 milligram edible would be like a completely reasonable dose for a completely reasonable person. More studies have shown that the more freedom in marijuana, the lower opiate deaths. Right after marijuana became legal in Colorado, there was a significant decrease in the opiate deaths. So people, instead of choosing opiates, would choose marijuana and they wouldn't die of opiate overdoses. And I mean, we're talking 17% decline in opiate fatality rate. And we'll see if there's any change in the opiate fatality rate in New York. And I truly hope there is. Severe toxicity is really uncommon. People get paranoid, people get agitated, people get cannabinoid hyperemesis syndrome, where they're just doing like scromicking in the back of the ambulance. There's not a lot we could do about it. But things like pancreatitis is uncommon. It can affect your heart. It makes people tachycardic. So if you have a heart that's not going to be able to tolerate tachycardia, then maybe marijuana isn't good for you. We've seen patients who are acutely intoxicated. We know it can cause hallucinations, memory impairment, et cetera, et cetera. I don't have to explain that. And if you do have a patient who comes in and they're just too darn high, the treatment, my favorite treatment for anything, benzodiazepines. I mean, if they're up here, we bring them down here with a little bit of Ativan or Versed. So again, 5-10 years ago, if I was giving this talk, I'd be done with the talk. I'd be like, hey, people get high, maybe get some benzos, then they go home. But we keep on messing with a good thing. In the 80s up into the 90s, the percent THC content of marijuana was somewhere in the 4% range. Now we're looking at marijuana like a plant has a 20% THC concentration. So people who would just get a little stoned before with just a hit or two are getting really, really stoned. And then they're creating butter and these incredible concentrates where you only need a tiny little bit, a few milligrams of this is going to get you stoned to the point of being paranoid. And people will call 911 because they're so paranoid. Smoking, it hits you quick, but it goes away quick. So they're going to be sick for an hour, maybe two. They'll be sitting on my stretcher trying to hold the mattress down so it doesn't float away, hiding under their blankets. You give them a ginger ale, you give them a turkey sandwich, and they feel better in a little while. The issue is with the edibles. Edibles have a delay of about 30 minutes to 90 minutes. So you give somebody, they're like, hey, I'm going to go party with my friends, and they take an edible, and all of a sudden it's like half an hour later and they don't feel it. They're like, well, I'm going to take another edible. And then they still don't feel it. And then they take another, and then they take another. Then they're starting to get high, and these edibles are starting to taste really good. And they go from having a party with their friends to being incredibly stoned. And these are the patients that are going to have those ventricular dysrhythmias, tachycardia. They can have MIs. And it lasts for 12 hours sitting in a hallway in the emergency department somewhere, getting a couple of doses of benzos here or there if they're just having like hallucinations. It's a very unpleasant experience. And it's everywhere. Like, if you ask somebody if marijuana is bad, it's hard to say marijuana is bad when you're seeing these advertisements for it. It's everywhere. Kids are seeing their parents use it. They're seeing their friends use it. So it is incredibly prevalent in society, and people don't think it causes problems. You can go to a dispensary. They literally have a menu of things that you can purchase. We all know those people who use it too much, right? Like, you can't say that marijuana doesn't cause, you can't live in this society, look around and say marijuana doesn't cause long-term damage, because there are those chronic users, the dazed and confused. And it's hard to say if marijuana itself is the chicken or the egg. There's definitely association with schizophrenia, psychotic symptoms. If you have a family history of psychosis and you're a heavy marijuana user, you're more likely to have psychosis. We don't know if that's because you are going to have psychosis anyway, but you are treating your symptoms with marijuana and that's your way of coping, or if the marijuana triggered you. But it does, in patients who use, especially at young ages, poor psychosocial development, poor education. And we think it does cause permanent educational cognitive impairment. And obviously, if you're smoking anything, it's not good for your lungs. There is a DSM diagnosis. Marijuana use disorder is a thing. You can become addicted to marijuana. Your body gets used to it. You have withdrawal symptoms if you don't take it. And prior to the last 10, 15 years or so, we didn't know that this was a thing because most people didn't smoke enough pot for us to realize. So marijuana is good for you. It's like, has very few side effects. Yeah, if you use it too much, it's not so good. But now, as more and more people are using it, we're doing more and more studies. We're realizing, oh my gosh, marijuana causes heart attacks. Death rates have increased in men and women. It's associated with the timing of cannabis and the use of cannabis. We're not sure if it's the chicken or the egg, but there are higher rates of myocardial infarctions in states that have legalized marijuana. So that's something we need to look at more closely into. There's a correlation with suicide, especially in teenagers. Is it causing suicide, or is it somebody who's so sad that they start using to kind of cope with suicide? Although there's fewer opiate overdoses, specifically in Colorado, there are increasing traffic accidents. Now, it's hard to think that it's going to be a very fatal traffic accident when you have somebody who's driving like 30 miles an hour paranoid, but they are driving 30 miles an hour paranoid, getting into traffic accidents. And those that are driving a little bit faster are getting hurt. People bleed. Marijuana makes you bleed ever so slightly, but you'll come in, you're stoned bejesus, and you're having a heart attack. They try to cath you and you bleed. And that's a direct result of the marijuana. And E-volley, we kind of forgot about E-volley when COVID happened, but E-volley was the e-cigarette. It was a lung injury caused by e-cigarettes. There were vapes with marijuana in them that also had, we think it was like a vitamin E analog. And when people would smoke them, it would cause significant damage to their lung. We knew at least about 3,000 patients were affected. 64 patients died, including kids and teenagers. Right as this became a really kind of big thing, that's when COVID started. So I think there was probably a crossover, and I think there were some misdiagnoses, especially in the early days. I think there were more deaths from E-volley than we know, but we just weren't able to test for COVID at the time. but they look very, very similar. The lung x-rays look absolutely similar. And additional risks, there, who knows what's in there, like depending on who you're getting it from, they could put absolutely anything in there. Solvents from production, heavy metals, insecticides are laced with PCP, and some are certainly laced with fentanyl. Kids are using it more and more. 32% of students of 12th graders had used marijuana within the last year in one study. And that's too much. Their brains are still developing. We have CBD1 receptors in our brains. We have CBD2 receptors in our brains. And when we are messing with our neurotransmitters, we are messing with our development. So when I say marijuana is safe, I am definitely not talking about pediatric population or developing brains. And kids see everybody using it, so they're using it too. And they're advertising it to kids. Like, I want to eat this. I'm hungry. I want to eat this stuff. You look at the Skittles container here and you're like, it says Skittles on it. Let me eat some. And unless you're paying attention, you might not notice the pot leaves on it, or this little teeny tiny sign over here that has a little pot leaf and exclamation point. You might not notice that it has 400 milligrams of THC in 20 pieces. If you remember, I said before, a novice user should have like 10 milligrams is a heavy duty dose for a novice user. So if you start eating a package of Skittles, either to get high or not, and you eat this entire package of Skittles, you will end up in the hospital. It will make you sick enough. You will call 911. You will come in. Your friends will call 911. Pot tarts, it's pretty hard. You very well could accidentally eat this. You could get this at a dispensary. You could put it in your cabinet. You could forget it's there, and your toddler could decide they want a Pop-Tart, and they could go ahead and eat that. And these have high concentrations of marijuana. Sometimes the dose of marijuana, or I'm sorry, the dose of a Pop-Tart is like a third of a Pop-Tart. I don't know about you guys. I've never in my life eaten a third of a Pop-Tart. So if you're giving me marijuana and telling me to only eat a third of one of these things, it's not going to happen. I'm going to eat the whole thing, and I'm going to end up in the hospital. And these things, you can't even tell that they're marijuana. Before legalization, and this is in, I think this is Vermont, in Massachusetts. Before legalization, there were almost no calls to the poison center for THC. There was just not a lot of marijuana use. And now people are coming to the hospital. People are getting sick. People are getting called into the poison center. And in terms of pediatrics, the number of calls on pediatric marijuana exposures have absolutely skyrocketed. So what do you see? You see that patient like we had earlier. You see lethargic patients. You see patients that you're like, should I intubate this kid? They can be, lethargic is the most common. They can be ataxic. Tachycardia is super common, but any dysrhythmia is possible, including like an alternating tachybrady symptom, which is very, very difficult to manage. They tend to be hypotonic. They can hypoventilate. About 6% of all patients that presented in one study ended up getting intubated. And I'm probably seeing these at least about once a week, once every 2 weeks, if not more frequently in Albany Med. So we are talking the Albany Med catchment area. Once every 2 weeks, I'm seeing one of these patients, and a small portion of those are going to get admitted to the ICU. They're going to get intubated. Nystagmus is really the symptom that you're going to see. That's like the telltale sign. Seizures are also possible. And you're not going to walk into a room and be like, oh, I walk into a house and be like, oh, this is a house full of druggies, because it's legal and people buy them for their friends as presents. One of my most recent cases was like this mom who was absolutely mortified, but somebody had given her a package of gummies, and her 3-year-old found the package of gummies, and she just didn't think that she needed to lock them away, keep them in the garage, keep them where the kid couldn't get them, because she just didn't realize how dangerous they could be. And that kid ended up getting admitted to the ICU. So 1 to 10 milligrams is a reasonable beginner dose for THC. By the time you're one of those people who's using every day, you're eating, 60, 70, 80 milligrams per dose. but they're selling it in 300 milligram packages. And it's not like it's a little pill and you only take one. These are gummies. It's really, people just don't know. It's 60 milligrams per piece. So if you're hanging out with friends and they're like, hey, you want some marijuana? And they offer you something like this, they might not realize this is going to absolutely ruin your day. So it can make you sick. It can get kids intubated, but can it kill you? I think yes. And there is one pediatric exposure of cannabis. A little baby, 18 months old, this was in 2017, got a hold of edibles, an edible like this that was 60 milligrams each. They ended up eating grams of THC. They were obtunded, they got intubated, and they ended up getting a myocarditis. We know that THC can cause myocarditis, and this patient was tested for everything else that could possibly cause myocarditis, and nothing came back positive. The patient died at around day 5 of hospitalization. There is no other explanation for this pediatric patient's death other than the THC. So it is very, very hard to die of THC. It has been used for thousands of years. But if you have a big enough overdose, a big enough exposure, it can absolutely kill you. And although the THC lobby does not want us to believe that this pediatric patient died of marijuana exposure, I absolutely believe that they did. So to conclude our case, this is what happened to our pediatric patient. They got into these. They ate about half of them, and the family had been kind of hanging out, kind of partying, being responsible, except they left these out. And this pack has 500 milligrams of THC. It could be split evenly somewhere between 10 and 50 people, and everybody could have a good time. But this one pediatric patient ate the vast majority of it. They ended up getting admitted to the ICU. They were very close to getting intubated, but they continued to maintain their airway. They did have intermittent bradycardia. We had atropine and epinephrine at the bedside. They never needed to use it because kids are resilient. We were ready for anything, but this patient slowly improved over 24 to 48 hours. And was discharged from the ICU. I think the next day, I think they kept them for 24 hours. Obviously, we're calling CPS on all these patients, but it truly can be an absolute innocent mistake, but it can be a very, very terrible innocent mistake. So one of our jobs is to protect these kids. And if you have friends that are using, if you have any of these products in your house, make sure they are away from children, because they market them to kids. They are colorful, they are delicious, and they can make kids very, very sick. And in terms of teenagers, although we're like, marijuana is good for you, everybody should be on marijuana, that is absolutely not the case for pediatric patients. For teenagers, it can very much mess with their development. For adults, we're probably using it way too much, and hopefully that levels out as the newness of marijuana goes away. And I think we're going to probably see more long-term problems with marijuana in the adult population as well. These are my 2 pediatric patients that I am trying to keep safe from the exposures to drugs in this world. I would love to answer any questions. And I told you, Art, I would go over just a little bit.
All right. There's not that there's a question, but Aaron Rosenberg put in, said, did you hear about the wedding party in Florida where the bride thought it would be cool and laced the cake with cannabis? And when the guests started getting high, they called 911 and the sheriff ended up arresting the bride. That's hysterical and really, really sad, which reminds me of the story of my patient in B28. That was back in like 2009. The son was upstairs getting a surgery and the dad was freaking out. So the daughter thought she would chill dad out by giving him a brownie. And she didn't tell him what was in the brownie. And he was a code gray. So he had like passed out in the cafeteria. And I came and talked to him. And I'm like, what's going on? And he's like, I don't know. I was just so hungry and I was just so thirsty. And he's like tachycardic. And the daughter had told one of our techs, she's like, I gave him a brownie. And I'm like, what, is he diabetic? What? Like, no, a brownie. So she had drugged her dad and he ended up in the emergency department. And then she bolted. She was like, I'm out of here. I called her. I got her phone number. I called her. I made her tell her dad that she drugged him, and he ate some pizza and she cried. So.
Hey, Molly, excellent talk. I've had a couple of these. I'm not any you know, as knowledgeable, but definitely have a question since I have the subject matter expert on there. So number one, so the DABs or whatever so from what I've been hearing is that problems with studying states that go legalization is, I think you mentioned in your talk, well, you did mention, I was listening, is that the cigarettes are not the issue. Because you mentioned, because the level is so, you got to just smoke so much.
Right.
It's dabs. And as you've highlighted, which we already knew that people are marketing, it's almost for children, the way they market, and you've highlighted that. It's so problematic. But is New York State controlling like the level? Because that THC level, or as you mentioned, there's other, is so problematic in trying to control studies, because apparently some states do regulate that. And is New York?
New York is, and even Massachusetts are way better. And I think we are learning from the mistakes out west. When in New York, I went to the dispensary in Lee, Massachusetts, and they're extraordinarily knowledgeable. Everything is packaged in like individual, clearly labeled packages. They really don't have the stuff that looks like fake candy, like the Potch Tarts or things like that. It's not as candy like. It's much better than some other states is. And it is much better marked. But you can still get a 60 milligram candy. You can still get a bag of gummies that are this big that have non-individually packed, but they just don't look quite as enticing to kids. So they're making some steps forward, but I don't think it's perfect.
So we don't have laws on packaging, which we did for cigarettes. I mean, that was one of the things they said they made that illegal. So I think that's important. And so we have no control. The New York State has no control on the concentration of these dabs, these products that you can.
I would have to look into that for the specific New York laws, because there's a lot that's changing because it's so brand new. Right. But we are doing, there is some legislation, there is some control. I just don't know the specifics.
And the other one that I had initially, but I guess it doesn't pan out, is, as you kind of mentioned, the incidence of psychotic break. Out west, they were initially saying that, but I think JAMA has done a better study. But like, because I looked at it in motor vehicle crashes, so I was very much interested in what you were doing as New York was legalizing it, to say, hey, what's going to go on with their motor vehicle crashes? I looked at some of those studies, like Colorado did, but Texas didn't. They had this kind of combined operation, and then New Mexico. So it didn't pan out that all the states had this increase in motor vehicle crashes with the legalization of marijuana. But they did initially say, well, we saw an increase in the psychotic breaks of adolescents. And then I guess something else has come out that it's not as much, but maybe there's a select people, as I think you mentioned in your thing, that are more prone to psychotic breaks, and using cannabis seems to raise that attention, right?
Yeah, there's 100% an association between psychosis and a later diagnosis of schizophrenia or one of the schizoid disorders and marijuana use. But that's
when I was looking at the motor vehicle crashes, that seemed to be the only, like, hey, what are you going to see in the ED more with this goes on? I didn't look at the pediatric side, so I really appreciate your discussion, but I didn't see there was a back and forth on motor vehicle crash increase rates. But I thought it was an excellent talk. Thank you so much.
No, thank you. And I think although we get a lot of problems with the adults, the real problem with this is going to be the pediatric population, because they're starting it young. They're doing a lot of it, and it's just changing their development. The CBD receptors or CB receptors are involved in neural development. And if we start messing with them at a young age, it is going to change our development. And I think if we were able to study it properly, we would see that it is a causative, not just a correlation of schizoid disorders. All right. Thank you, everybody. I appreciate your time. I'm always around for questions. It's Boyd M is my email address. Happy to answer any questions or talk offline.